We are now live.
Thank you. I'm going to go ahead and begin. I'd like to welcome our audience and thank you for attending today's webinar on obesity, entitled The Obesity Epidemic, a Ticking Time Bomb. The University of Nicosia is hosting today's webinar to celebrate the European Public Health Week in conjunction with the European Public Health Association. This year's European Public Health Week aims to highlight the importance of public health and showcase how individuals and organizations across different sectors are working towards addressing issues that affect a global population through local actions. The University of Nicosia Medical School is pleased to participate in this initiative and contribute to raising awareness about the critical role of public health in our communities. I'm Danagra Ikossi. I'm a general surgeon and director of the Graduate Entry Medical School program here at the University of Nicosia. It's my privilege and pleasure to be your moderator today. Obesity has emerged as one of the most important public health problems around the world. The relationship between increasing obesity and increasing prevalence of associated diseases and the increasing mortality can not be overstated. The associated risks of type 2 diabetes, hypertension, dyslipidemia, and coronary artery disease are well established. Today's daily kickoff event for the European Public Health Week was a session on obesity and cancer. Our panelists today will explore this specific relationship between obesity and pregnancy, sexuality, and the role of lifestyle medicine. I would like to introduce our expert panelists, we are very honored to have here with us today. Dr. Arul is professor of OBGYN here at University of Nicosia. He is Professor Emeritus at St. George's University, visiting professor at Imperial College London. He received his MBBS with honors and his diploma in child health from the University of Ceylon and his MD and PhD from the National University of Singapore. His accomplishments are too many to list, but briefly, he is the president of the International Federation of Gynaecology and Obstetrics, Royal College of OBGYN, the past president of the British Medical Association, and has authored innumerable books, chapters, and peer-reviewed publications. He is also the editor-in-chief of Best Practice in Research in Clinical Obstetrics and Gynecology, and is a member of the editorial board of many international obstetric and gynecologic journals. His research and clinical interests are in understanding and improving the quality of life for women and newborn babies. Dr. Dionysios Vaidakis is clinical assistant professor at the University of Nicosia Medical School. He studied medicine at Semmelweis University, and he holds a master's degree in public health from the National School of Public Health in Athens and a PhD in gynecologic oncology from the National and Kapodistrian University of Athens Medical School. His research interests include subfertility, fertility preservation in oncologic patients, and application of modern technologies in health promotion. Dr. Maria Cecilia Mosquera is assistant professor here at University of Nicosia in the Department of Primary Care and Population Health. She trained in the United States at LSU for her MD and MPH and did extensive residency training thereafter. She is certified by the American Board of Pediatrics, American Board of Preventative Medicine, American Board of Obesity Medicine, and American Board of Lifestyle Medicine. Her research focuses on obesity and lifestyle modification. It is my distinct pleasure to hand the floor to Dr. Arul to learn more from him about the impact of obesity in pregnancy.
Thank you very much for the kind introduction. I'm going to get my PowerPoint presentation ready. So I'm going to talk about obesity epidemic, a ticking bomb, and obesity and pregnancy, a reproductive hurdle. So in my talk, I'm going to talk about those who are over 30 BMI and over, which is obese, and of course, it applies to extremely obese who are over 40 BMI. The other is 25 to 30 is overweight. The epidemiology-wise, in Australia, there are about 67% women, 52% of men who are obese, and the figures for different countries are given. For Cyprus, from the newspaper reports I gather, it's 25% in males and 22% in females, as seen on the slide. But the projection for obesity is rising, and as you can see, from 2007 to 2025, it has gone up from 16, it will go up from 16 to 32% in South America, but if you take the Europe, it's going to go from 24 to 44%. Or the biggest will be in India and China, where it will go from 46 to 80 million. And with that, there will be an increase in the number of women and men who have diabetes, as was mentioned by our chairperson. Now, when it comes to pregnancy, there are issues related. Pre-pregnancy, they have menstrual disorders and infertility. In early pregnancy, they have miscarriage and fetal anomalies, and difficult to spot them by ultrasound because of the obese panels. Antenatally, they have pregnancy-induced hypertension, preeclampsia, gestational diabetes, venous thromboembolism. In labor, they have shoulder dystocia, cesarean section, operative anesthetic complications, and post-delivery more chance of hemorrhage and thromboembolism. And of course, the baby is macrosomic and suffer more perinatal mortality and morbidity. This is a study looking at risk of miscarriage. As you can see, it's 3.5 times more common to get recurrent miscarriage if a woman is obese. And early miscarriage is about 1.2 times more. But if you talk about recurrent miscarriage, it's much greater because there might be some underlying thrombotic phenomenon as well with obesity. Now, when it comes to structural birth defects, it is from the National Birth Defects Prevention Study. After exclusion of and control mothers with GDM, there were possibility altogether 7 birth defects, of which 3 seems to be very specifically increased in obesity. Those are spina bifida, heart defects, and diaphragmatic hernia significantly increased. The picture you see is an ultrasound being done on an obese mother, and sacrococcygeal teratoma is very specific to obesity and diabetes. This shows in form number of birth defects which are increased. With the increase in obesity levels, the types of abnormalities increase, and you can see spina bifida, neurotube, hydrocephaly, and cleft palate and hair lip are much less compared to the major defects of the spine, central nervous system, and the cardiac. Now, the main problem is about suboptimal ultrasound visualization. This is a large study from 11,000, and you can see 38% were obese, who are more than 30, and nearly 49% of craniospinal structures could not be cardiac, 49%, and craniospinal, 31%, could not be identified based on ultrasound. And you can see the percentage visualization of 10 anatomic components. And if you look at normal underweight population to obesity class 1, then you can see the number of visualization drops, and when it is class 3, it becomes much, much less. So we might miss congenital malformation on the scan. If we move on to preeclampsia, this is a study from the United States, as you could see from the left-hand axis. As the BMI increases, the chance of preeclampsia increases. It moves from 1 to nearly 2.5%. And if you take those with BMI over 40, then the risk becomes even much greater. So body mass index has an influence on the development of preeclampsia. And the same study is repeated in Scandinavian population, says the same thing, as we could see with the increase in BMI on the horizontal axis. You can see the first column, the incidence of preeclampsia increases. And this is again looking at Scottish data and looking at preeclampsia on the first column. With the increase in BMI, there seems to be increase in the incidence of preeclampsia and eclampsia. So there's no doubt that whichever country we take, there is an incidence. Then we talk about weight reduction, and before they get pregnant, and it has been shown that if you can advocate weight reduction and about reduce the BMI by 1.6, then the incidence of preeclampsia can be markedly reduced. So it should be our duty to advise mothers to control their diet and cut down their weight and the BMI so that they won't develop complications. Gestational diabetes, again, is much greater. The more obese the person is, the greater the chance, and also they have macrosomic babies. So preeclampsia, gestational diabetes. The next is about spontaneous labor. The obese mothers don't go into spontaneous labor so easily. compared to normal weight mothers. And this is a study controlling for age, smoking, deprivation, and type 1 diabetes. Still, the more obese they are, they have less chance of going into normal labor and less chance of having vaginal delivery. The increase in obesity reduces the chance of having normal vaginal delivery. On the other hand, the cesarean section rates goes up with increase in BMI, as we could see here. If it is over 35, there's about 2.5 times greater chance of getting a cesarean section. And if they have a vaginal birth after C-section, there's a greater chance of scar dehiscence if the woman is obese because of increased intra-abdominal pressure. So there's 6 times increased morbidity because of obese and failing the trial of labor and possibility of scar giving way. Now there are problems with the operative issues as well. You can see the woman being supported on a table. If the woman is more than a certain weight, we need special operating table in terms of weight bearing and in terms of the dimensions. So only some hospitals can take on that can support weights up to 225 kilograms. Not all hospitals are equipped to do that, and there should be special lifting equipment. And when it comes to anesthetic issue as well, the spine can be deformed with increasing obesity. Some, even if they're obese, can have a straight spine. Others, there will be a challenge to have an epidural or spinal put in, and general anesthetic has a major risk with obesity. So this is in a nutshell. As you could see, SVD, spontaneous vaginal delivery, decreases as the BMI increase, and the cesarean section increases as the BMI increases. So there's no doubt based on pooled studies. And as the BMI increases, not only planned sections, but emergent sections also increase and going nearly up to 50%. I mentioned about thromboembolism. That is also much greater. And we know some of the clotting factors are increased with obesity, and therefore we have to plan not only on the booking visit, but also an admission to labor. And whenever she is admitted for some other condition, then we should really reassess her, especially in labor and post-delivery. And it is known that because of these complications, there is a much higher chance of maternal mortality. This is one of the reports, 30% of women who died had a BMI over 30 and 10% had BMI over 40. Now coming to the baby, the macrosomic baby, they have low ABGAS scores and cord pHs, traumatic delivery with feet fractures and brachial plexus palsy due to shoulder dystocia, and increased chance of admission to the neonatal intensive care unit. Now the macrosomic size increases with increase in BMI of the mother. As you could see, if there is over more 50 BMI, then she has a 32.6 chance of having a macrosomic baby, causing difficulty in labor and post-delivery. And proportionately, the neonatal unit admissions will be also increased with increasing BMI. And the incidence of stillbirth again is increased. As you can see, the greater the BMI, greater the incidence of stillbirth. And this is looking at nulliparous and parous women. And predominantly, the stillbirth seems to be greater in nulliparous women, the first-time mothers. So we had to really advocate for weight reduction for first-time mothers itself. So the management plan, in summary, would be to have a transvaginal ultrasound for accurate assessment of gestational age. In the first trimester, second trimester, detailed ultrasound for fetal anomaly, although it might be difficult now with non-invasive prenatal diagnosis from maternal blood, we can offer chromosome analysis. In the third trimester, we had to look for abnormal glucose metabolism, and if positive, consider management with diet and metformin. And later third trimester, we had to look at the placentation and the placental site and consider induction if the baby is going to be macrosomic, and consider prophylactic heparin and elastic stockings to prevent thromboembolism. And in labor, we had to remember high incidence of postpartum hemorrhage, and also the babies at risk, we should employ fetal monitoring, proper pain relief, and think about risk about operative delivery and shoulder dystocia. So I would like to thank you, but in summary, I would like to say it's not only the mother who gets affected with obesity, the fetus, and we know that adult disease is now dependent on fetal origins of non-communicable disease. So we should try and avoid before they get pregnant and in between two pregnancies to reduce their weight. Thank you very much for your kind listening.
Thank you, Dr. Arul. That was phenomenal and very interesting. It's raised so many questions. I'd like to let our audience know that we're going to take questions at the end. If you'd like to put some of your questions in the chat, or you can reserve them and ask them at the end as well. We'll have the panelists answer them all together. Dr. Dionysios Vaidakis, you are up next. You're on the floor.
Thank you very much. Just give me 1 minute to...
If our attendees could let us know, are you able to see the slides? Is everything all right? You can write in the chat if you'd like.
Can you see my presentation?
Yeah, it's coming up.
Yes,
Okay.
we can.
Thank you very much. First, I would like to thank the organizing committee and Professor Arul for the invitation. The subject that we were going to cover is the role of obesity and how obesity affects sexuality. As Danagra said earlier, and as Professor Arul also indicated in his presentation, obesity can affect many aspects of life. Also can affect sexuality, and this, as a result of this, affect the overall well-being of person, and as a result, and the quality of life, of course, and as a result of this, affects the overall idea of health. So we will cover the role of obesity on sexuality. Before we start, it's good to give some definition. When we say human sexuality, we mean the sum of all human behaviors related to sex and gender identity. In order to see how any disease can affect sexuality, we also need to see the term of sexual function, so the functionality. The functionality is characterized by the sex response cycle. There are two different models, and you can see here on your right side of your screen, this is the linear model. It's for both male and females, they use the same. It's an old model, we don't use it any longer, but it is important to know. It's characterized by the sexual desire that leads to the excitement and arousal. The arousal has a plateau, and the climax of arousal is called orgasm, and after that we have a resolution. So all the organs return back to the pre-arousal condition. In men, there is sometimes a long refractory resolution period between the next erection and sexual intercourse. In the women, we observe that there are different patterns. As you can see, pattern A, there is a typical like excitement, plateau, orgasm, and then this can be followed by the next one and the next one until we have the resolution. Other alternative is that, like B, it's that there is no climax, but a prolonged arousal period and then a resolution. Or it could be a quick desire, arousal, and orgasm, and then a quick resolution. Because of these changes, it's not like, so we decided, Professor Basson, 2020, published the circular model of sexual cycle, because as you can see here, the response in women is not linear like men. So it included the idea of sexual intimacy, sexual stimuli, arousal, and also the emotion and physical satisfaction, the terms of all these that can affect the sexuality. So we see that women have much more complex sexuality. But both models, they start from the same point, which is sexual desire or sexual drive. Sometimes in some authors, they divide sexual desire into instinct, it was called libido, or sex drive. Sexual desire is controlled by cortex, higher centers of the brain that located in the cortex, and also some from hormones. Characteristically, men, here is controlled, the desire in men controlled mainly from testosterone, which is the basic sex hormone, and in women is from estrogen and progesterone. And there are other hormones or molecules that can affect positively or negatively the dopamine system and at the end the desire. Apart from this, there are other behaviors that are characteristic in human sexuality, like sexualization, intimacy, sensuality, of course, sexual identity, and what is important here is sexual health and reproduction. So sexual health and reproduction can affect human sexuality. Let's see now how obesity can affect the sex life. First of all, it can affect directly or indirectly, and it can affect individually, male or female, and as a couple. As we said before, we will see how obesity can affect the sexual functioning. Here, it is important to remember that obesity and obesity-related comorbidities, like diabetes, etc. So obesity and related comorbidities can impair the sexual function. In men, the most characteristic and the most common is erectile dysfunction, but can affect also sexual desire. So we have sexual desire disorders, sexual arousal disorders, orgasmic disorders, and all of these can affect the cycle as we described it earlier. So directly it's affect there by altering the hormones. So in men, we observe that among obese persons, there is an increase in sex hormone binding globulin. As a result of this, we have lower free testosterone level. So the testosterone is the one that is related with desire. Increase estrogen because the abdominal fat produce uncontrolled estrogen. And as a result of this, estrogen has a negative feedback to the gonadotropins, so lower FSH. And as a result of this, it's a cycle. Lower testosterone, lower desire, and it's a cycle. As a result of this, and this is what, as a result of this, we have low libido, low desire or sex drive. But this is I think that it's very important, and we will see it later with Maria's presentation. This is the importance of child obesity. So if we have a child that is obese, we have sexual dysplasia or retarded sexual development. So we may have low testosterone, maybe we have hypoplastic sex characteristics and sex and external and genital organs and dysfunction and sexual dysfunction, of course. Similarly, in women, we observe higher androgen level, higher total and free testosterone levels. So as a result of this, we may have some androgenic effect. So hirsutism, abdominal obesity, etc. And also we have the uncontrolled estrogen production that can cause disorders in menstrual cycle. And as a result of this, we have changes in the secondary sex characteristic. And here, as hormonal always, we may have increase in the sex drive. But as we will see later, because it's controlled by the level by centers in the cortex, the overall sexual desire of obese women is lower, even though the sex drive is higher. As we said before, we have obesity can affect men, women, and as a couple. So it can affect dating and relationships. One of the most common reasons why obesity can affect relationship is stigma. And as we know, at the beginning of a romantic relationship, some things we don't see it, but later in life, when this couple is growing, obesity can affect the sexual function of the couple. Also, apart from functionality and the indirect effect on dating and relationship, we also have obesity can affect satisfaction. So the sex is not satisfactory. And as a result of this, we have further decrease in the sexual drive, from the cortex in this time. So we have less sexual desire. There is also some physiological mechanism that can relate it to this by indirect. So for example, patients that they have diabetes, they can have problems in their vessels, and apart from the from erectile dysfunction in men, we can also have difficulty to get a climax in women, so orgasmic disorders. Also, some sex positions tend to be limited, and as a result of this, the sexual intercourse is more like specific positions, and this will affect the satisfaction. We described this before about the erectile dysfunction, and among women, here this is very important, both among men and women. It's not necessary to be at class 3 obesity in order to experience all this dysfunction, but also slightly persons that they have even normal BMI or a little bit higher than the normal one, they can experience all the sexual dysfunctions we said before, just because obesity affects the body image, and as a result of this, affect the self-esteem. And this is controlled by society, by what is normal, what is beautiful in society, and all of this can affect the sexuality. Thank you very much.
Thank you, Dr. Vaidakis. That was fascinating. And I know we're going to have a lot of questions at the end from our attendees as well. I'd like to now give the floor to Dr. Maria Cecilia Mosquera, who will speak to us about obesity and lifestyle medicine.
Thank you very much. I will share my presentation and would welcome confirmation when you can see it.
We can see it.
Great, thank you. So if for some reason the attendees can't see it, please just let us know in the chat box. So after these wonderful presentations that highlight the challenges posed in pregnancy and with sexuality with obesity, we're going to delve into a related arena where we hope we can discuss not only challenges but opportunities. And this is where we're talking about obesity and lifestyle medicine. So as I'm sure many of you are aware and has been briefly mentioned today, obesity affects many body systems and can lead to type 2 diabetes related to insulin resistance, dyslipidemia, hypertension, heart disease, etc. Today, we're going to focus specifically on some aspects that perhaps you traditionally don't hear about obesity. But this is in the context of the theme for our panel today, where we're discussing the fact that this obesity epidemic is at a ticking time bomb. And this is in the context of our recent COVID-19 pandemic. So if you have been looking at the recent studies that have been done, looking at the effects of the COVID-19 pandemic on weight and weight-related issues, including overweight and obesity, the question that we need to answer is, are we seeing or will we be seeing worsening obesity rates, and understanding that we were already in the midst of an obesity epidemic? So the literature is starting to consolidate the information that we have to date, and there are some highlights in particular aspects that people are exploring, such as weight gain, changes in eating habits and dietary patterns, and physical activity that may be leading to overweight or obesity that is worsening in different age groups across our planet. So for example, we see this systematic review meta-analysis that was just published in May 2023 that shares with us that in adults, the COVID-19 pandemic was associated with an increase in weight. And you can see that in children, there was also an increase in weight. However, the question remains, what is the impact? What is the clinical significance of the level of change that they have seen in weight? And what is that going to translate to when we consider the rates of overweight and obesity in children, adolescents, and all age groups? And what can and should we do about it? So this is where recent literature is trying to tease out this information, but in the interim, we need to act on the fact that we understand that many people in the world are already overweight and obese, and there are some things that we can do about it. And that's where lifestyle medicine comes in. So the definition of lifestyle medicine, according to the American College of Lifestyle Medicine, is it's an evidence-based approach to prevent, treat, and even reverse diseases by replacing unhealthy behaviors with positive ones. So lifestyle medicine doesn't deal only with obesity. It also deals with many other chronic diseases such as type 2 diabetes, heart disease, etc. So the focus is on using the evidence, the literature, the research that we have today to help prevent, treat, and even reverse diseases. When we talk about obesity, the importance is considering the challenges that were mentioned in pregnancy and in sexuality posed by obesity, that we obviously want to focus also on prevention, management and treatment, and even reversal of the disease of obesity to see if we can help people with their well-being. So how do we help people replace unhealthy behaviors with positive ones? Well, there are different areas. Perhaps traditionally you think about nutrition and physical activity, but there are also other areas in which the evidence shows we can focus, and we're going to be discussing those today. What's important to remember is in our panel today, actually we have people that focus on children, on adults, on women. Obesity is important, and the management of obesity, prevention, reversal of obesity is important across the life course. As Dr. Vaidakis mentioned, we have to consider preconception, and we think about the effects of a pregnant mother on an infant, on their future infant's adulthood and adolescence we know is impacted. So we need to think about not just adults, but pregnant women, children, adolescents, the elderly, the entire life course. Part of what we understand, and you can see this is from the WHO European Regional Obesity Report published in 2022, is that it's highlighted that if we can intervene in an early life stage, perhaps we can enable the next generation to start life at a lower risk for obesity and other the related chronic diseases. So in lifestyle medicine, I mentioned that we use the evidence to focus on helping people reach behaviors that can optimize their health. And in lifestyle medicine, there are 6 pillars that you see here. As I mentioned, people traditionally think of evidence around healthy eating and physical activity, but perhaps we think less, or we're discussing less the other aspects of health that can be important for when we talk about, for example, obesity, but other chronic diseases and well-being, which include managing stress, having healthy relationships, sleep, optimally restorative sleep, and avoiding risky substances such as tobacco and alcohol. So today I'm going to go through each one of these 6 pillars of lifestyle medicine to highlight some of the concepts that we know related to their relationship to obesity. I can't mention everything, but we'll highlight just a couple of concepts. And perhaps you've noticed, if you look at the news, I saw this today, you see information in the news and the literature about diet. This is the topic that we're perhaps the most familiar with, regardless of whether we're in healthcare or not. So today, this is an article that popped up in the BBC about a study that was just published around plant-based diets, and heart health. So although we're not talking about heart health specifically today, it highlights the fact that, this is what's in the news. This is what people are aware of. People understand that diet and weight are related. But it goes beyond what the food that you eat. So healthy eating is not just about the content of your diet, the quality of your diet, although we know that there is evidence that if you focus on a plant predominant diet, such as the whole food plant-based traditional Mediterranean diet, or a whole food plant-based diet that doesn't include any animal products, for example, that these dietary patterns can help prevent overweight and obesity, can help treat and manage overweight and obesity, and even reverse some of the clinical signs and symptoms. But not just obesity, we know that they also can impact type 2 diabetes, heart disease, etc. As I said, it's not only about dietary patterns. It's about the impact of fasting, for for example, which is a question that many people and patients pose to us today, is what is the evidence and research around the different types of intermittent fasting, for example. Here's a systematic review on alternate day fasting and the impact it has on BMI, on your body mass index, and fat mass. Another area of consideration beyond just dietary patterns is the role of chronotype. So are you the kind of person that likes to wake up early and go to bed early, or are you the type of person who likes to go to sleep late and wake up late? So people are studying the relationship between chronotype and obesity, and there's some evidence that shows that, for example, there's a higher association with obesity when you consider people who have that sort of eveningness, the preference to go to sleep late and wake up late. But also of consideration now is what people are starting to understand about the importance of the gut microbiota, the gut microbiome, in relationship to overweight and obesity. So healthy eating has to include concepts that go beyond just what you put on your table. And you can see here that although I have mentioned that lifestyle medicine has 6 pillars, in reality, they're all interrelated. So when we talk about chronotype, we consider the relationship between sleep and diet and weight, for example. So moving on to the second pillar of physical activity, many people know and understand that physical activity can help prevent or minimize weight gain. There's a reduced risk of becoming obese for those who do the highest level of physical activity and compared to the lowest level of physical activity. And there's a higher risk of becoming obese for people who are physically inactive. So think about that as you're sitting in your chair watching this presentation. But what perhaps we don't discuss as often as we should, beyond healthy eating and physical activity, are the other pillars of lifestyle medicine, including managing stress. So we know that the impact of, for example, in children who have adverse childhood experiences, for example, trauma in childhood, there's a relationship between those children who have those experiences and adult obesity. But it's not just children who could be impacted with obesity based on their experiences related to stress. We know that in adults, for example, stress is associated with eating more unhealthy foods and eating less healthy foods. In order not to only mention challenges, I will say that in lifestyle medicine, the evidence gives us information about these relationships, but people are also working on interventions to try to address issues. Mindfulness-based interventions is one area that people are evaluating and trying to study and understand in relationship to managing stress. For example, there's a systematic review that was relatively recently published that saw a small effect on stress reduction when people utilize mindfulness-based interventions in the shorter term, 3-month period. So the understanding that we need to gain is about how do we impact stress in the longer term. Moving on to the 4th pillar, which is about healthy relationships. Following up on the discussion we've just had on sexuality, there are evidence across many fronts that your relationships can impact your weight and increase your risk for overweight and obesity. One interesting consideration is that weight is influenced by your social network. For example, if you are overweight, you're more likely to have people in your social network who are overweight. And there is also a relationship between your neighborhood social capital and obesity. And social capital are the resources that are accessed by individuals and groups through social connections. I highlighted the last point on this slide, that there's a study that highlighted that parental childcare, so when grandparents are caregivers, they saw an association with a 30% increase in childhood overweight or obesity risk. So not to point out that, it's not to say that it's dangerous to have grandparents as caregivers, it's just to highlight that when we're talking about the pediatric population, for example, parental or caregivers' attitudes, behaviors, even their own weight status is of consideration. And those relationships between parent and child, or friend and other friend, or couple between one spouse and another spouse, all of those relationships are part of what we're trying to understand more in order to it can help us facilitate how to leverage the social connection between people to think about how we can improve these considerations for overweight and obesity. Moving on to the fifth pillar, which is sleep, or specifically helping people get restorative sleep, there are a variety of studies that have shown that poor or inadequate sleep, poor quality sleep can lead to weight gain and obesity, but also that obesity can lead to sleep problems such as obstructive sleep apnea. So it seems to be a cycle of consideration. And when we talk to our patients or discuss with our communities about overweight and obesity, we're not very often discussing how they're sleeping. And what's important to recognize is that it's not just how long they're sleeping at nighttime, which would be sleep duration, but it's also the timing of their sleep. So when they go to sleep, when they wake up, the efficiency of their sleep. So how long it takes them to fall asleep, how well they sleep, and do they remain asleep during the nighttime, and how do they wake up in the morning, but also the quality of their sleep. So beyond just discussing patients, perhaps some of you are asking, how long did you sleep at nighttime? But perhaps many of us are not discussing the other aspects of sleep that can be important and have relationships to chronic diseases such as overweight and obesity. And considering that sleep is a factor that depends upon a balance of many other factors that include the time of day, for example, when somebody had a meal, the content of that meal, whether it's full of salt, whether they drank an alcoholic beverage, what time of day they exercise and what type of physical activity they did, and all these other factors that are of consideration. So we're not very often perhaps considering the concepts that are related to sleep. And this is where lifestyle medicine as a pillar has highlighted that sleep has evidence behind it, that it's something that we need to consider for overweight and obesity, and actually many other chronic diseases, and also for human well-being. So if we move to the last pillar of avoiding risky substances, and if we mention specifically alcohol consumption, so the research shows that with alcohol consumption, there is a relationship between higher food energy intake, increased total energy intake when you consume alcohol. And alcohol intake has been associated with increased odds of overweight or obesity, and abdominal obesity. And heavy alcohol drinking has been positively associated with overweight, obesity, and also abdominal obesity. Now, these relationships are still being teased out. When we look at the literature in recent years, if you've been paying attention to alcohol and overweight or obesity, there's some questions about different levels of overweight and obesity and different levels of consumption and what those relationships may be. But it is something that we need to consider when we discuss with patients, not just their food intake, but what are their alcoholic beverages they consume. And also, perhaps we don't often think about tobacco in relationship to overweight or obesity. Perhaps our considerations with tobacco are more related to other things like lung cancer, heart disease, etc. But there is an association when discussing, for example, pregnancy and the outcomes of children, that when children have prenatal exposure, infants have prenatal exposure to environmental tobacco smoke, there is an association with later childhood obesity. In addition, there's some recent information that tobacco smoking may actually alter the genetic susceptibility to overall adiposity and body fat distribution. So tobacco perhaps should be part of our conversation when we're thinking about overweight and obesity. So we've highlighted the 6 pillars and just a few examples in each of the relationship between obesity and each one of these pillars to try to remind us that it's not just about what we have on our plate. It's about what our sleep routine looks like, what the quality, duration, etc. of our sleep is, what are the relationships like that we have in our lives, what skills, coping skills, what tools people utilize to manage their stress, and what are the substances that we're consuming. So why does this matter to the people in the room? Those of us who are perhaps health or public health professionals? Well, for the clinicians in the room, we need to consider lifestyle factors if we're going to be talking about obesity prevention and management, treatment, or reversal. And perhaps you discuss diet, but are we discussing as a group of clinicians sleep with our patients? Are we discussing the other aspects of lifestyle that are important for obesity? Perhaps not. And that's important because as clinicians, our own personal habits, for example, it's important to know, can impact the way that we counsel. An example of that would be, for example, with physicians who engage in physical activity are more likely to counsel patients about physical activity. And there are relationships around different aspects of lifestyles, different clinicians. So our personal habits can impact how we counsel our patients. So it's important to remember that it starts with us as individuals. And also, our counseling of patients can impact their behaviors, which is what we hope, obviously, when we're starting to discuss with patients behavior change. But it makes a difference what we as clinicians do in our own personal lives to the impact we can make in our patients. But it also makes a difference if we discuss and counsel patients on behaviors that can help them prevent, manage, treat, reverse obesity. And this is of consideration not just for clinicians, but for those that are public health colleagues or students that are in the room, because we need to think about not only on the face-to-face one-on-one interactions that we have with our patients, how can we optimize and support them through behavior change that leads to outcomes of well-being to help prevent some of those challenges we saw with obesity and pregnancy and obesity and sexuality, for example, in the earlier presentations. So there are public health interventions that can happen that can target some of the determinants of health that may be likely to make a difference when we're considering this ticking time bomb of the obesity epidemic. And these interventions should be considered along the entire life course. So preconception, remember I mentioned, for example, prenatal exposure to tobacco can lead to childhood obesity. So we need to think about preconception. We need to think about early childhood, older children and adolescents, and strategies for adults and the elderly. And we know that there's evidence that the earlier we intervene in the life course, we have the opportunity to make hopefully a difference. So clinical and public health professionals that are in the room, part of our conversation we hope can be is that to remind us that the research and the evidence has highlighted that there are factors beyond even healthy eating and physical activity that have an important role in obesity, such as sleep, which perhaps we don't discuss as often as we should. We should, as clinicians, always assess and discuss and understand the lifestyle factors of our patients to see how we can work together with other healthcare professionals, but also with our patient to support them in optimizing their healthy behaviors. And for all of those of us who are health and public health professionals, we need to also remember that it starts with us. We are our first patient. So we should remember that our own health is important, but also that our habits, as I said, can impact our patients. So the idea is that to be able to help all of us as individual healthcare and public health professionals, but our patients and our community members to have well-being, to allow them to live their life as they would wish to live it. So thank you very much for your time today. We'll go ahead and stop sharing my presentation.
That was a wonderful, wonderful summary and so organized. I learned such a great deal from each of you. I was going to give our panelists a chance to answer some of the questions that have been placed in the chat. Is everybody here? So Masawar Niazi has asked, what are your thoughts on the effect of circadian rhythm dysfunction on obesity?
Shall I assume that one comes to me, perhaps? So I will say that I don't know the research in the literature around circadian rhythm dysfunction, but I would be curious to see what relationship has been highlighted. And I'm sure that there are opportunities to continue to explore. obesity and all the other aspects of lifestyle are perhaps, like such as sleep, are perhaps less investigating than healthy eating and healthy eating patterns. So, but I will say that I don't know the specific research yet around the dysfunction in the circadian rhythm. And I think if anybody else happens to have information about that, I would welcome their thoughts.
All right. Do we have any other comments?
No, I have no knowledge about circadian rhythm and obesity, so I'll keep quiet.
So I'd like our...
If I may add,
yes.
I think Maria gave a very excellent presentation about the relationship in obesity and sleep, and circadian rhythm affects normal sleep. So maybe indirectly there is a link somehow. I don't know.
So does anybody have any other comments or questions that they'd like to ask? Anything you'd like to chime in? You're welcome, Masawa. It looks like we have a paucity of questions. I hate to not give everyone a chance. So I'm actually very curious, Dr. Arul, if you could tell us what you think the causes of the birth defects might be, or do you think that it's simply that we're not able to identify the birth defects because of ultrasound?
No, the incidence of birth defects are increased in obesity. In addition to, even if you control for diabetes, the cardiac defects, neural defects, and gastrointestinal, especially diaphragmatic hernia incidence is increased with obesity. And the greater the obesity, the greater the number of defects. That is part of the problem. Part of the problem, as you mentioned, is poor visualization of the structures, especially when the baby's heart is scanned. It's a very small organ at 18 weeks, and it is beating all the time. We had a 4-chamber view or a 6-chamber with aortic pulmonary duct flow. And then if there's a bone across, then that also throws a shadow. And with the woman who is more obese, we have less chance of visualizing. So both are correct, that the incidence is increased, even if we control for diabetes, but also we miss some of the defects because of poor visualization.
Do you think that this is the increased incidence is potentially a hormonal effect from the obesity, or is there an issue of the pressure? Increased hormonal pressure?
No, it's mainly because if you look at the cardiac defects and the neural tube defects and so on, seems to be stemming from fusion deformities where things should come and join. And this is also seen in folic acid deficiency and in epilepsy, those on anti-epileptic drugs and so forth. So that's why obesity, diabetes, we give 5 milligrams of folic acid starting at least 2-3 months before pregnancy, up to 12 weeks at least. So despite high dose of folic acid, this incidence is happening, but the reported incidence has been in a mixed population. So maybe by introduction of folic acid, we can bring down this incidence, but still there might be other factors in play.
It's very interesting. Sameli Yorgiu asks, how would a functional medicine approach to obesity management differ from a lifestyle medicine approach? How has one shown to be more effective?
I'll take that as a question for me. So from what I understand of a functional medicine approach, it is a systems-based approach that tries to identify the root cause of a disease. And I will say that lifestyle medicine, in fact, overlaps with this. Lifestyle medicine is a term that has been developed, I think, in the last 10 to 20 years that has built upon all the other aspects of research medicine that we have to date. So in reality, it's not like lifestyle medicine is a new concept. It takes what the evidence has shared from many other aspects of prevention. For example, I'm a public health preventive medicine physician. Preventive medicine and lifestyle medicine are not really separate. although they are different sort of certifications, these concepts overlap. So I would assume that, there is much overlap between functional medicine and lifestyle medicine approach. I think what the highlight of lifestyle medicine as it has been defined, and as I mentioned, for example, the American College of Lifestyle Medicine, but there are also other institutions like the British College of Lifestyle Medicine who have similar pillars, is that they focus specifically on those pillars and they focus specifically on the evidence. So I would see that as having an overlap with functional medicine. As to whether one works better than the other one, I'm not sure that actually has been compared to date. And I actually see that the concepts work well together. So I know people who perhaps espouse different aspects of training in medicine. If you can be a lifestyle medicine physician and be an orthopedic surgeon, be an ear, nose, and throat doctor, be a DO from the US or an MD from the US. You can really be from any background and fields. And so I can imagine that functional physicians can also adopt lifestyle medicine concepts. It would be focused around those 6 pillars, although there are other aspects in the research and evidence, with the purpose of utilizing the tools that can help people with behavior change. So the focus is helping people optimize their behaviors to lead towards optimal health, and using their research and evidence about that. Hopefully that answers your questions. If you would like further clarification, please feel free to add it in the chat box, or I don't know if people can unmute themselves as well.
I was speaking with my mute on. Does anyone have any other questions? Otherwise, I'm going to ask one to Dr. Vaidakis. Dr. Vaidakis, how do you feel that the information that you presented can be best used in counseling patients in the clinic, since obesity is so stigmatized and this is sort of a delicate issue of sexuality and sexual function? How do you use this knowledge that you've imparted on us today in your daily practice as a gynecologist?
Yes, thank you for the question. It's we are all clinicians. We face the same problem in our everyday practice. As you know, most of the women, and mainly men, they don't speak about sexual dysfunction, and they are trying to avoid this conversation. So I think, and what I do in my practice is that I bring up this subject. So I'm always asking, first, we need to establish some level, a certain level of rapport and communication with the patient. And after that, you can ask more intimate questions like this and focus more in the sexual history. And since we have the knowledge that obesity can affect there, we can ask directly if we have a couple that one of the 2 partners are obese. So we can directly bring this conversation, and we can uncover, and you will be surprised that most of the patients, they experience some level of sexual dysfunction. So the best thing is for us to have the proper knowledge how to deal with this, not necessarily to treat all of these conditions, but to refer to a specialist. But the first thing and the most important is to diagnose it, to figure it out that there is a problem. So we just need to ask the patients. And it's not that common. Most of the clinicians, you know, that due to the effort, due to the everyday practice, the appointments and the operations, etc., we usually do not have we don't have the time to properly evaluate all these issues. But it's something that it's our responsibility to figure it out.
That's a very nice answer, and your patients are very lucky to have you. Are there any other questions or comments?
Can I add to that? Is that okay?
Oh yeah,
just to say that yes, asking and assessing is always the first step. And just like we know, for example, that physicians who have physical activity in their own lives are more likely to talk to people about physical activity. We also know that it's harder for physicians themselves to ask questions about topics that feel less comfortable to them. And that applies to things such as alcohol use. People feel more comfortable talking about diet than alcohol use. And although I haven't seen the literature, I can imagine that similar concepts apply to sexual health. You know, if it's challenging for you as a healthcare professional to ask the question, and you don't have time to do so, perhaps you're less likely to discuss it. And that's why it's important we're having this conversation today, because if we don't know, we don't have the possibility of helping and working with our patients to address it.
That's very well said. All right, well, I think we've answered all of our questions. You are so welcome, Natasha. She says, thank you for this interesting presentation. And Dr. Alon, our infectious disease specialist, also thanked the panelists earlier. If you have any other questions, folks, now's the time. Otherwise, we're going to wrap it up and thank everyone for their contributions and their time.
Thank you.
Thank you, Dr. Arul, Dr. Vaidakis, Dr. Mosquera, for spending your time, your evening with us, and for educating us on these very interesting topics, which are less talked about than others.
Thank you very much.
Thank you.